Hello. So we are going to be talking about hyponatremia, and when it comes to hyponatremia, the first thing that we have to understand is that sodium in the body is determined by an interplay or balance between sodium and water. And hyponatremia is not as much a disorder of sodium as it is a problem of having excess water in the body compared to sodium. So that's important to know. And also, what is important to know is what regulates water in the body. So, of course, it's the water that you drink, and primary polydipsia can lead to hyponatremia. But in addition to the water that you intake, there is also a strong or very important role that ADH plays, antidiuretic hormone, in water regulation. It's also called arginine vasopressin, and as you recall, this stimulates water reabsorption from the distal collecting tubules and leads to overall retention of the free fluid. So ADH in turn has a very important role to play in sodium level of the body. And as we will discuss in this presentation, there are many conditions in which ADH is high, either appropriately or inappropriately, and that high ADH is leading to hyponatremia. Before we move on, we also have to find out or discuss what are the factors which influence ADH. So there are two factors in body which stimulate ADH. One is thirst, and thirst is determined by osmolality of the body, and there are osmoreceptors in the brain, and in response to increasing osmolality, they increase the ADH production. And the second stimulus to ADH secretion is hypovolemia. And hypovolemia is a more potent stimulus for ADH as compared to osmolality. Because, if the osmolality is low, then you would think that ADH secretion would go down. But let's say that the osmolality is low, but the hypovolemia also exists, so the volume is also low. In that case, the ADH secretion would still continue. In other words, volume kind of trumps osmolality when it comes to ADH secretion. And there are a few conditions in which body would be hypoosmolar but still hypovolemic, or either truly hypovolemic or perceived hypovolemia, and that leads to increased ADH secretion and hyponatremia, increased free water retention, and hyponatremia. Okay, so we're going to discuss all that. This is important formula to remember. You might already be familiar with it. Plasma osmolality is determined by 2 times serum sodium, and by plasma glucose, and by BUN, and each of them, they have their different roles to play. Okay, so now we're discussing hyponatremia, and I belong to the age group where we memorize hyponatremia according to the NEJM article published in the 80s, which divided it according to hypovolemic, hypervolemic, and euvolemic. And that was a very good way of memorizing the causes of hyponatremia. The one of the downside of that is that it was not very practical, because different physicians can differ on the volume status of a patient. Some physicians might say, well, this patient is euvolemic, whereas others might say that no, this patient is hypovolemic, and or hypervolemic, or so on. So the algorithm or the way to memorize or remember or understand the causes of hyponatremia that I'm going to present right now, that depends on the labs. And labs, numbers don't lie. So the labs will help you to pinpoint with a fair amount of certainty and accuracy what the underlying problem is that is causing hyponatremia, and then you can do something about it appropriately. So first thing is first we have hyponatremia. So what do you do when you have hyponatremia? You check serum osmolality. The serum osmolality will be either low normal, or high. If the serum osmolality is low, this is what we call hypotonic hyponatremia, and this is the big bucket in which all our common causes of hyponatremia reside, such as SIADH, CHF, cirrhosis, polydipsia, all that. It kind of resides in this bucket, and this is called hypotonic hyponatremia. In the next slide, we'll discuss the causes of hypotonic hyponatremia. In this slide, what I want to discuss is the causes of high serum osmolality with hyponatremia and normal serum osmolality with hyponatremia. So, what are the causes of high serum osmolality with hyponatremia, also called hypertonic hyponatremia? So, very simply, either the patient has hyperglycemia, as we saw in the equation that I showed on the previous slide, that plasma glucose also determines osmolality, and if the plasma glucose is high, then your total serum osmolality could be high despite the fact that the sodium is low. And the other cause is exogenous solutes, which are affecting the plasma osmolality in a similar fashion as glucose, and commonly used in clinical practice are mannitol and sucrose. So these are the causes of hypertonic hyponatremia. Then what are the causes of isotonic hyponatremia, or hyponatremia with normal serum osmolality? So this is also called pseudo hyponatremia. So let's discuss this for a second. That what do you mean by pseudo? What is pseudo about it? Well, as you know, that blood has 55% of plasma, and the remaining components are the cells. And plasma has, this is plasma that we are talking about, has about 92% of fluid and about 8% of proteins, albumin, globulin, fibrinogen, and the 92% is water. And of course, when we measure sodium, we measure sodium in this part of the blood or of the plasma, and we are making an assumption that we are checking sodium in plasma, which is 92% of fluid. Now, what happens in conditions in which you have excess protein? This proportion might increase. So it might be that they have 15% non-fluid part of plasma, such as proteins, albumins, or fibrinogen, and the plasma fluid component is now reduced to 85%. So the amount of sodium in the fluid component of plasma actually has not changed. It's just that the total composition of plasma has decreased, and that's why it shows up as hyponatremia. And that's why it's called pseudo-hyponatremia, because it is mostly almost like a lab error that it cannot tell us whether it's true hyponatremia or not. Anyway, so what are the conditions which cause pseudo-hyponatremia? There's hyperproteinemia, such as multiple myeloma. Then we have hyperlipidemia and hyperbilirubinemia. Okay, and then we have hypotonic hyponatremia. So let's talk about hypotonic hyponatremia. So when you encounter hypotonic hyponatremia, and that is hyponatremia in which serum osmolality is low, as it should be, then you check urine osmolality. And the urine osmolality would be either low or high. If it's low, then you think of two major causes of hyponatremia. One is primary polydipsia, in which they drink so much water that they have simply overwhelmed the kidney's capacity to concentrate urine, and that's why the water is they have overwhelmed the kidney's capacity to excrete water, and that's why the water is in the body, and they are excreting a very dilute urine. And the other cause is solute deficiency, because kidneys do need solute to excrete water, and if there is solute deficiency, then the kidneys cannot excrete water. And we see that phenomenon in beer belly potomania, in which patients are just getting their calories from beer or alcohol and not having enough salt in the system to excrete water. Or we can also say it a tea and toast diet. Again, there is solute deficiency or salt deficiency, which is a primary problem here. If your urine osmolality is high, then we come back to ADH, because we talked about in the first slide that ADH is what causes reabsorption of water from the distal collecting tubules. So if the urine osmolality is high, then you can say that ADH is at work here. So you can also say that this condition is not ADH dependent, because here, if ADH was a major player in causing hyponatremia, you would have seen a high urine osmolality. And in these conditions, ADH is a player. Now, so what are those conditions in which ADH is high? Well, SIADH, in which ADH is inappropriately high. Then we could have volume depletion, and we discussed that depleted volume is a potent stimulator of ADH. So maybe the patient is volume depleted, and that's why ADH is high. And there could be other conditions in which ADH could be high. So how do you kind of fine tune what condition it is? So the next step is to look at urine sodium. So the urine sodium is either going to be low or high. If it's low, that is, it's less than 20, then you look at the volume status of the patient. If the patient is hypervolumic, then the conditions associated with hyponatremia are cirrhosis, heart failure, nephrotic syndrome, and most likely your hyponatremia is due to one of these conditions. Okay, so what happens here? So these patients are hypervolumic. So why is ADH being oversecreted? Well, the simple answer is that they are hypervolemic because they are third spacing, and their intravascular blood or effective circulation volume is low, and the kidneys perceive it as a decrease in the effective circulatory volume, and that's why they secrete ADH to retain more fluid, and that's why this is an ADH dependent mechanism. And as we'll talk about in treatment part, that here the ideal treatment would be to stop the fluid and to give patient diuretics and put them on a salt and fluid restricted diet, and that's how you will treat hyponatremia in these patients. So if the volume status is low, that is, patient is hypovolemic, then you are looking at true volume depletion. And of course, with the volume depletion, ADH is again being secreted, but it is being secreted because volume is indeed low in the body, which happens in vomiting, diarrhea, burns, etc. Okay, so just to recap, hypotonic hyponatremia, you check urine osmolality. If the urine osmolality is low, you think about primary polydipsia or solute deficiency. If it's high, you check urine sodium. The urine sodium is low, then you think about either true or perceived circulatory volume deficiency. If the urine sodium, however, is above 40, then you're dealing with SIADH. Okay. Now, before we go further, let's talk about causes of SIADH quickly. So what are the causes of SIADH? I'm going to just write it here. So, in clinical practice, drugs are very important. The most common drugs that you must have seen are SSRIs. They cause SIADH. NSAIDs are also an important cause of SIADH. We also know that lung tumor, especially small cell lung cancer, is associated with SIADH. Any lung pathology, sometimes something as simple as pneumonia. Shouldn't say simple, but something as common as pneumonia, or respiratory failure that can cause SIADH. So we have drugs, we have tumor, we have CNS causes such as stroke. These are some of the causes. Other important causes include intense exercise, such as after running a marathon, you can have SIADH. Post-op patients who have nausea and pain. So pain and nausea are also ADH stimulant, and that's kind of preparing the body for fight or flight reaction. So post-op patients can also have SIADH. So these are some of the causes. The list is definitely not complete by any means. By the way, other than SSRIs and NSAIDs, which cause hyponatremia due to SIADH, one important drug that you have to remember is hydrochlorothiazide, which can also lead to hyponatremia, not necessarily due to ADH overproduction, but can lead to hyponatremia, and that's something you need to remember. Okay, So after we have hopefully this foundation on the causes of hyponatremia and how different causes can be evaluated and pinpointed with a fair amount of accuracy, let's talk about how you would approach hyponatremia. So you have a patient with hyponatremia. First, how I like to do it is, of course, check for TSH, consider adrenal insufficiency, and those patients will have obvious signs of adrenal insufficiency, such as hypotension and other associated things. I also make sure that I DC SSRIs, I DC NSAIDs, and I DC hydrochlorothiazide if they are on it. Okay. And after that, I also check serum osmolality. If your serum osmolality is high or normal, then you consider the causes for hypertonic or isotonic hyponatremia, as we discussed. And you should also check a blood alcohol level, because alcohol can cause serum osmolality independent of sodium. So sodium might be low because of some other reason, but alcohol might be in the system raising the serum osmolality, and these might be two separate things going on at the same time. Obviously, if patient is appearing drug or intoxicated, then that should be your clue to checking blood alcohol level. Okay. If your serum osmolality is low, then you are thinking that either it's primary polydipsia or solute deficiency or SIADH or true or perceived volume deficiency. In that case, you check urine osmolality. If your urine osmolality is less than 100, then you consider polydipsia or solute deficiency. If urine osmolality is above 100, then you check urine sodium. If urine sodium is below 20, then you consider true volume depletion. And in those cases, the patient will be truly volume depleted, they will be hypotensive, and they will be clinically dry. Or fluid overloaded states, such as cirrhosis, CHF, or nephrotic syndrome, with hypervolume and third spacing. And those patients will have, pedal edema, JVD, and lung crackle, etc. If your sodium is above 40, then you consider SIADH. Lastly, what if the patient is volume depleted and urine sodium is between 20 and 40? So in that case, the answer here is that patient maybe is on diuretic therapy because diuretic is still salt in the urine. So you hold diuretics and recheck. And you should also consider several salt wasting in patients with intracranial hemorrhage or other serious conditions. Okay, so we have come this far. Now just look at in another way is what are the expected findings in each of the conditions. So what are the expected findings in SIADH? As you recall, they should have hyponatremia with low serum osmolality, high urine osmolality, and high urine sodium, and clinically they are euvolemic. In patients who are fluid overloaded state, they should have everything similar to SIADH except they have low urine sodium because of the perceived decrease in the effective circulatory volume, and they are clinically hypovolemic. Volume depleted states, again, the only thing different from the SIADH would be that they have low urine sodium, and also they are clinically volume depleted. The only thing different in fluid overload compared to fluid overload states is that they are clinically volume depleted. And lastly, we have polydipsia, in which we have low serum osmolality but low urine osmolality, and clinically these patients are euvolemic. So now that we have covered thus far, let's look at some clinical scenarios. First clinical scenario is schizophrenic patient, and just saying that schizophrenic patient should give you a tip off that here we are possibly dealing with psychogenic polydipsia, low serum sodium, urine sodium is low, but urine osmolality is 70, it's less than 100, which tips you off that either this is primary polydipsia or solute deficiency. The patient started on water restriction, and the urine osmolality is increased to 450, and started on DDAVP, and the urine osmolality is increased to 600. So the answer here is that this is psychogenic polydipsia. Patient with small cell lung cancer, again, small cell lung cancer is associated with SIADH, has a serum sodium of 130, low serum sodium, and high urine osmolality and high urine sodium. This is consistent with SIADH, and the answer here is that this is SIADH. Now, what if there is a the clinical picture is not jiving with the numbers? So you go with what the numbers tell you. For example, if this small cell lung cancer patient had low urine sodium, in that case, you would have said that this patient is probably clinically volume depleted, and you might have wanted to give them fluids. So, just to say that clinical picture is important, and most of the cases in both the clinical picture should jive with the numbers which are being given. But if you think that the numbers are not kind of jiving with the clinical scenario, that means a tricky question and probably an unfair one. But I would go with the numbers more, as we have discussed, rather than the clinical picture.